Today I'll be doing a lecture on navigating the US healthcare system. Many questions in USX will either touch on or be about the healthcare system, and there are many misconceptions that people have that can make research really difficult or might get you ranked down if your judge knows about like how healthcare works in the US. And I think it's just important to have a lot of baseline knowledge about this that you can draw on when preparing speeches. So today I'll cover how insurance works. This is a big one. Private insurance, Medicaid, and Medicare, they are distinct. That's something I'm going to cover later. The Affordable Care Act and the recent One Big Beautiful Bill Act and its impact on Medicare and Medicaid, as well as the Affordable Care Act, as well as telehealth and healthcare in rural areas, because these are questions that you're very likely to, or subjects that you're really likely to get questions on, especially during the upcoming season. So how does insurance work? I think it goes without saying, like healthcare in the United States is extremely expensive, but insurance terminology can be like really complicated, and there's a good chance that like your parents deal with most of this stuff. So you may not know too much about it, and that's fine. It's actually really simple if you kind of just break it down into its constituent parts. So what does the US healthcare system look like? It's essentially funded by a combination of public programs, private insurance, and out-of-pocket payments. Um, so some people qualify for government assistance, others don't, and have to buy private insurance. And pretty much regardless of what insurance you get, be it public or private, like you'll definitely have to pay out of pocket to some extent. And most importantly, the United States doesn't have universal health care, which means about 9% of the US population is currently uninsured. This number was a lot higher prior to the Affordable Care Act being passed, and unfortunately, it'll probably be a lot higher in the future as well. We'll touch on that later. But these are essentially the main ways that healthcare is paid for in the US. Some important insurance vocabulary. So insurance, you probably already know what this is, but it's just a program that covers a part of a person's healthcare costs. An out-of-pocket payment is essentially a cost not covered by insurance, and a deductible is how much money you have to pay out of pocket before the insurance benefits kick in. So let's say that you have a deductible of $2,000. Your insurance won't pay for anything before you spend $2,000. So I'm just pulling numbers out of thin air right now, but let's say um, you go for an appointment at your PCP and it costs you have to pay an $80 like basically the cost of the appointment is $80. None of that will be covered by insurance because you've only spent $80 and you have to pay $2,000 for the insurance program to start covering anything. Let's say like then you go get your wisdom teeth removed and that costs like $2,500. Oh wait, actually dental's not really covered. Bad example, but anyways, let's say you spend $2,500 on another procedure, then your insurance will start covering um that money. So until you spend as much money as your deductible is, your insurance is not going to help you out. Um, and if anyone has any questions at any time, like feel free to put them in the chat. But yeah, like, and the reason that deductibles are usually so high is because healthcare procedures in the United States are usually really expensive. Like, um, medication, can be crazy expensive if it's not covered by healthcare, and things like that. Oh, about pre-existing conditions, I'll get to that in a second, when we talk about the Affordable Care Act. So private insurance. This is essentially like insurance that you get if you don't receive government assistance. It can be employer based, essentially tied to your job. 60% of Americans have employer based insurance. Um, for example, if your parents have employer-based insurance, you'll also have it most likely as a dependent. It can also be directly purchased from insurers, which is really expensive most of the time. Like that's why only 9% of Americans have this type of insurance. Or it can be university-based. You're pretty much never going to get a question on this, I think. So like you don't really need to worry about it that much. To be fully honest, I don't really know how it works, but it's not really that relevant to Extemp. As for employer-based insurance, though, this is often a reason people aren't willing to leave their jobs because, their job may have really good health insurance coverage, or, if they quit, they may not have access to health insurance anymore, and they may have some like chronic condition or, you know, depend on medication that would otherwise be incredibly expensive. So, generally, the healthcare premium, which is the cost of the healthcare plan, is covered about I can't read that number. It was being covered 85% for the employee themselves and 75% for their dependents, um, basically their children. These are approximations though. It does vary a lot, but that's how the vast majority of people on private insurance get health insurance through their employer. And in both cases, insurance usually doesn't cover many drugs or treatments. After like the whole Luigi thing, there were a bunch of memes about like, denials and stuff. Insurance can absolutely deny your claims, and it'll often be because they'll claim for some reason that, it's not a necessary procedure, or they'll try to have you do some other kind of procedure beforehand, or they just won't cover it in any case. Um, and a growing problem is the use of artificial intelligence to determine which claims should be rejected. Um, in fact, I think United Healthcare at one point was rejecting like 90% of claims for a particular demographic because its AI was doing that. And you'll likely get a question like where this might be relevant, especially because these AI systems are extremely faulty and can often result in patients incurring massive costs that, ordinarily would be covered, but weren't because a faulty AI system denied their claim. That's also another reason healthcare is so expensive. Even though you pay for insurance, insurance doesn't want to pay for you. They'll do literally everything they can in their power to deny claims. And that's a major area in which the US healthcare system needs reform. So, Medicare. Do not confuse this with Medicaid. Medicare and Medicaid are completely different. They sound very similar. I even like said the wrong one in the conclusion during my NSDA final speech, which I'm still beating myself up for today. Like, just be careful not to say the wrong one. Medicare is government-sponsored insurance for citizens 65 years of age and older, as well as some Americans with specific disabilities. But generally, if you get questions about Medicare, it'll be about senior citizens. You don't really need to know these four parts that are written out on the screen, but essentially, this is a vital source of healthcare for many senior citizens in the United States, especially because, they no longer have a job, which means, after they retire, they may not have access to their employer healthcare plans. So this is essentially like a major source of healthcare for them, and cuts to Medicare would be devastating for the senior population in the United States. But yeah, what you're more likely to get questions on though is Medicaid, because far more people are on Medicaid. Medicaid is health insurance for low income Americans, um, regardless of age. You can qualify for both, but essentially, like if your income falls below the poverty line in most state or in all states, you qualify for Medicaid. But in certain states that have adopted what is known as the ACA or Affordable Care Act Medicaid expansion, if your income is 138% or less than the federal poverty line, you also qualify for Medicaid. And essentially, Medicaid and Medicare are both just insurance programs for the people who qualify for them. Um, the degree to which they cover, you know, different procedures and how much of the cost they take on is generally far less than that of private insurance plans. But they still go a long way for covering essential healthcare procedures and things like that. But something that you are likely to talk about is the coverage gap. So essentially, the Affordable Care Act, which was passed in 2010 and which I'll cover in the next slide, expanded the Medicaid program so that you didn't just have to be below the poverty line to qualify for it. If you had an income 138% of the poverty line, so slightly above the poverty line or less, you would also qualify. Um, but in states that didn't adopt this expansion because, states had the discretion to decide whether they wanted to implement it, and some didn't, you may be essentially just above the poverty line, so, not low income enough to qualify for Medicaid, but also not well resourced enough to purchase private healthcare insurance or insurance on the marketplaces, which is what I'll get to on this slide. So the Affordable Care Act, which was passed in 2010 and is also known as Obamacare, was one of the most significant reforms to healthcare in the United States. In history. It was passed in response to extremely high uninsurance rates among the US population. I don't remember the exact number, but it was significantly higher than it was today. And it included many provisions, such as the creation of the marketplace, which was essentially a platform to buy health insurance for Americans whose incomes are low enough to qualify for it. And it also provided subsidies to low income families to purchase marketplace insurance. These subsidies would be provided and allocated according to their ability to pay and their income. These marketplaces essentially allowed people to have a central platform to buy healthcare and get funding to pay for these healthcare plans. And it was revolutionary because a lot of people who, didn't qualify for Medicaid or the Medicaid expansion that the ACA put out, would still be able to get affordable or at least semi-affordable healthcare. And to be clear, Medicaid is separate from the marketplace. The marketplace is a platform to purchase private healthcare insurance with government funding. Medicaid is just an insurance program operated by the government. And going back to that question earlier, it also prohibited discrimination based on pre-existing conditions. So let's say like you have COPD or something, you're likely to have significantly higher healthcare costs than other people. Like you might be on oxygen, you might need surgeries, you might need different medications to stay alive. You probably have to go to the ER from time to time. Prior to the ACA, you were kind of screwed. Like private insurance providers were allowed to essentially just turn you away and say, no, we're not going to insure, or we're not going to insure you because we know that you'll cost more than the average healthy patient. Which means these people often died with enormous amounts of medical debt. But the Affordable Care Act prohibited that kind of discrimination and required private healthcare providers, or rather private insurance providers, to cover these patients. It also prohibited discrimination based on gender, which was another major change that hadn't been implemented before. It also mandated the coverage of preventive services. And this is extremely important. These services are like mammograms, to screen for breast cancer, like prostate exams to, check for prostate cancer. And these have saved millions of lives um, since the passage of the Affordable Care Act. And a way to talk about this in speeches is to really emphasize and highlight how much money has been saved by mandating preventive services. Like it's obviously a lot cheaper to do a mammogram than to pay for someone's chemotherapy, if they have breast cancer. It's a lot cheaper to do like lung cancer screenings than it is to treat lung cancer. Which itself has a very poor prognosis. So like it also saved lives as well. But also like reduced the burden on the healthcare system. So this is something that, you know, there was a lot of pushback about, but there's less pushback about it now, mandating preventive services, because it has indeed saved a lot of resources. And something that also was really important was that it allowed dependents to remain on their parents' insurance until the age of 26. So even though you're an adult, you're living on your own, you're still able to benefit from your parents' insurance until that age, especially because the first job you get probably won't give you very good insurance. Like that's just how it is. Don't DNA companies sell data to insurance companies? I'm afraid I don't really know about that. I don't think you'll ever be asked about it in Extemp, so I wouldn't worry about it too much. Um, and of course, discrimination based on pre-existing conditions is still massively illegal. Um, but more recently, just last month, Donald Trump's One Big Beautiful Bill Act, or OBBBA, I hate that acronym, was passed. And one of the reason it made headlines across the United States was because of its massive impact on healthcare. So due to cuts written into this bill, um, somewhere in the range of like 700 million to a billion, with respect to Medicaid and Medicare, more than 17 million Americans may lose their health insurance by 2034. This was an estimate by the nonpartisan Congressional Budget Office. So yeah, it's going to be extremely significant, and disastrous. So it introduced work requirements, which on paper seems like a good thing. Like in a vacuum, it would make sense, but it's not always possible for people to work. And even if they are legally exempt, um, due to physical disability, for example, it's extremely difficult to prove that inability. So the bureaucratic nature of, well, like everything in America, but especially healthcare, will inevitably result in many people getting kicked off of Medicaid and Medicare, or well, not necessarily Medicare because work requirements haven't been written into that, but definitely Medicaid. Um, More importantly, though, it also limits states' ability to raise revenue for their Medicare and Medicaid programs through mechanisms like provider taxes and state-directed payments. This is something that is a bit difficult to explain, you know, concisely. I would recommend that you do some reading on this yourself. Um, the Kaiser Family Foundation has plenty of great articles on these topics. But essentially, it restricts their ability to tax healthcare providers and then use that money to fund um, their Medicaid and Medicare programs. And it also restricts their ability to like essentially distribute funding, federal funding, according to hospitals' needs. Like that's what state-directed payments are. It removes some of their discretion when it comes to doing that. So it can, massively decrease the amount of funding that many healthcare providers get. And it also reduces funding provided to states to operate their Medicaid and Medicare programs as well, which will inevitably result in people getting kicked off of um, these programs because they'll have to be shrunk. And something that I forgot to write, but is also extremely important to know, is that the funding and for these subsidies for the marketplace are expiring at the end of this year, at the end of 2025. And nearly all Republicans in Congress have indicated that they don't support a renewal of these subsidies, an extension. So there's a very real chance that these marketplaces will run out of funding in the near future, and that would be disastrous for healthcare. Because people who rely on these marketplaces will just lose their healthcare coverage, and because their income is obviously higher than that needed to qualify for Medicaid, they'll have to spend a lot more on healthcare, which they likely won't be able to afford, um, given that they needed the marketplaces in the first place. So it'll be disastrous. Yeah, many more people are going to be uninsured, and it'll make the problem of medical debt so much more severe. Um, so what's the GOP's incentive to attack public healthcare access? Um, it is true that the GOP's supporters will be overwhelmingly impacted by these healthcare cuts. In many cases, more so than the Democratic voting base. I'm not exactly fully sure about what their strategy is. To be fully honest, healthcare lobbyists and other interest groups definitely played a major role in this. But these bills were also written, or this bill was also written to kind of like delay the implementation of many of these provisions until after the midterms. So let's say like the Democrats do really well in the midterms. Like, this bill will still be in place. And once these provisions finally take place, it'll appear as though the Democrats were responsible for much of the harm. And yeah, like as people have said in the chat, the main goal of cutting these healthcare programs was to reduce the federal spending deficit, which has long been a major talking point of the GOP, and a major part of their policy platform. So I'll also talk about a major technological innovation, telehealth. So what is telehealth? they're essentially medical services provided virtually through platforms like Zoom. That's a massive generalization and oversimplification, but like it's essentially remote healthcare that doesn't require you to travel to like a brick and mortar facility, basically. Like you don't have to travel to a physical in-person clinic. And use of telehealth massively increased during COVID because it was a lot more difficult for people to leave their homes. And now over 50% of Americans have used telehealth services at least once. And it's obviously not possible to treat many conditions, if not most conditions, via telehealth. Like, obviously, you can't perform like a tooth extraction or like a knee replacement surgery, over telehealth. That's just not possible. But many important healthcare services can still be provided through telehealth, like mental health care, follow-up appointments after surgery, to check someone's recovery process, and also the management of conditions like diabetes and hypertension, because patients can use like blood pressure cuffs and such and other measuring devices from home and share that information with their provider for for virtual meetings, and it reduces things like travel time and costs, and also reduces treatment costs. And yeah, telehealth is what people had to do during the COVID-19 pandemic. A lot of appointments had to become virtual because, it just wasn't safe to go outside and be out in the open. And an extension of telehealth would be satellite clinics. These are a really good solution for questions asking about how to make healthcare more accessible in the United States. These are generally operated by hospitals in geographically remote locations, so like far away from um, a hospital's main campus. They're usually staffed by nurses and nurse practitioners without actual specialists present because they're digitally connected to them. So, like, for example, nurses and nurse practitioners may, like, do like the data recording and like all the in-person work essentially, and share that information real time with like an OBGYN who may be on call via Zoom or something, and they'll be able to basically care for a patient in real time. And this increases accessibility greatly, especially for things like high-risk pregnancies. Many mothers with high-risk pregnancies in rural areas and other underserved areas aren't able to go for, regular checkups to ensure that everything's progressing as it should. And that can result in high maternal mortality rates, you know, stillborn, stillbirths, like, lots of tragic things. And satellite clinics essentially, they're not a complete replacement for in-person healthcare, but they go a lot further than, just not having access to these services entirely. And I initially intended to include more in this section. Unfortunately, I ran out of time when making this presentation yesterday, but the area that you'll most likely get questions about is rural areas. So rural areas are majorly underserved in the United States. Like 65% of rural areas are facing physician shortages, but some recent estimates put that number as high as 80%. And like 20% of the US population lives in rural areas, which means that like 1 in 5 people, slightly less than 1 in 5 people, about 1 in 6 people, I guess you could say, you know, don't have access to a physician. And due to a lack of Medicaid reimbursement to rural hospitals, over 100 rural hospitals have closed from 2013 to 2020, and far more are at risk of closing within the next few years. And now people have to travel more than 20 miles on average for, a medical appointment. And the reason that this is the case, that rural hospitals are closing, is essentially that rural hospitals have far more patients on Medicaid than urban hospitals. And generally, as a result, they're more dependent on Medicaid reimbursement. It's already expensive to operate a hospital in a remote area, and if Medicaid isn't reimbursing them enough, they'll have to either shut down departments or certain services that they provide, such as maternity wards, or just close down entirely. And that's why so many rural hospitals are um, are shuttering now, are being shuttered. And I worded this terribly. I meant to say that there are very few medical students graduating in rural areas, not people, medical students. Because the vast majority of medical students study in urban areas and then remain in those urban areas. Very few actually like return to the rural areas where they came from. And that just means that the number of physicians in rural areas is just decreasing and decreasing. So a potential solution to this problem is creating more residency programs and providing funding for those residency programs in rural areas, because people are more likely to, stay where they graduated, and it'll address the problem at its root. And another important thing is increasing Medicaid reimbursement to rural hospitals, which unfortunately is not going to happen anytime soon because the OBBBA is cutting Medicare and Medicaid funding enormously. Not only are they not going to be able to provide more funding to these hospitals, they'll likely have to grapple with even less funding than they currently have. These hospitals have extremely low profit margins. Many of them are operating like deep in the red, and no pun intended. And like the number of hospitals that will likely close in rural areas going forward is probably going to be like insane. And yeah, that's about it. I also forgot to make a thank you slide, but if anyone has any questions, absolutely feel free to ask them.
So based on the rural areas information, so would you say this the threat to funding essentially creates this negative feedback loop? Because you mentioned like the hospital is already operating in the red, like and struggling beforehand before the funding cut, and then the lack of medical students graduating. So that's kind of what's part of what's feeding this problem in rural communities.
Absolutely, yeah. Like, I mean, if it's already so difficult to operate in a rural area, you're probably not going to want to work there. And the fewer physicians there are, the more stretched resources are, the higher costs get, and yeah, the more hospitals close. So you're exactly right. Yeah. Melinda?
What are good like proposed solutions for like the physician shortages? Because I see those type of questions a lot. Like, are there any you would recommend us to like research, look into that
Yeah,
are
so
feasible?
there was actually a bipartisan bill. I think I actually mentioned this in my NSDA final speech, proposed by a Republican and a Democratic senator to create like 20,000 new residency positions in rural areas. Um, as well as provide funding to like operate those residency programs. And that would massively increase the number of people, um, or rather the number of physicians in rural areas, because I would assume part of the deal is that like if you participate in, these residency programs, you'll have to work in these rural areas for a certain number of years. And as Tavante said, like it's a negative feedback loop when people leave, but it's also a positive feedback loop when physicians, you know, begin to flock to these areas because it'll help revitalize their healthcare, um, or rather like hospitals in these areas and stuff. So there are also like I know it's a bit of a stretch, especially given that the OBBBA is massively cutting Medicaid funding, but increasing Medicare reimbursement or Medicaid, sorry, even I mess them up sometimes, a lot of the time actually. Even like Medicaid reimbursement is still important, extremely important to keeping rural hospitals open and also making rural hospitals attractive places to work at because they're vital to ensuring physician pay is high enough that people actually want to stay there. Like only by ensuring that it's actually worthwhile to be employed at a rural hospital, can we ensure that they don't close down? Yeah, go ahead.
So with these hospitals, like especially the rural ones, relying on like Medicaid reimbursements, uh, like how do private hospitals do it? Like, um, because I guess I had in my mind that this kind of incentivizes like the privatization of like healthcare, but like how exactly like is private healthcare just so extremely expensive that it's able to bear the burden of these costs, or is it that like Medicaid suffers from the much larger amount of people it has to cover?
That's pretty much exactly what it is. Private insurance is a for-profit business, and as a result, like, they have a lot more money to cover procedures and stuff. That's actually why many hospitals don't accept Medicaid, because they know that it won't be as profitable. Rural hospitals don't have that luxury though, because most people who live in rural areas are on Medicaid. So, um, but yeah, like the reason that rural hospitals are especially vulnerable to Medicaid cuts is because just like, so much of their patient base is on Medicaid.
Okay, so like private hospitals or private healthcare, just from the fact of like that all of their patients like have to pay out of pocket or like directly to them, that's why they're able to like stay open so effectively.
Um, well, not necessarily. It's just that like Medicaid often can't reimburse hospitals to the same extent that private insurance can. Yeah, Emma.
So earlier one of the slides said that like like 17 million Americans could lose their insurance by 2034. But then by then, like I guess how hard would it be to like because I know they already signed the big beautiful bill into action. So then is there anything that can be done to stop that? Because that's after Trump's term ends unless he decides to like overthrow this or something.
Yeah.
But like, how hard would it be to stop or like write a new legislation that would render that part of the bill void or something?
It would require a Democratic majority in both chambers of Congress, as well as Democratic control of the presidency, because even if Democrats gain control of both chambers of Congress in next year's midterms, they won't be able to reverse the OBBBA because Trump will just veto their bill to reverse it. Like, it basically requires Democrats to control both the legislative and executive branches. If they do, though, they'll be able to pass a bill reversing all of these harmful provisions. Unfortunately, that's not likely to happen. Well, that can't happen until earliest 2028. And even then, it's far from guaranteed. So it's very likely that, these provisions won't be rolled back anytime soon.
I see. And then kind of like unrelated, but since you mentioned that Democrats would have to have control of the legislative and executive branches, and since it has seemed that way that they like control it for the past few years, not besides for like Donald Trump's presidency, has there ever been a time when I guess like Republicans and Democrats have had like equal control or like somewhat equal control? Because lately it just seems like, oh, like Democrats have full control or oh, Republicans have full control. And it just seems like very like,
Yeah, like actually, before the 2024 elections, Republicans controlled the House, but Democrats controlled the presidency and the Senate. So split control is actually, I think, honestly, more common in American history than like one party having control of all three, or I mean both branches.
okay, thank you.
Yeah, of course. Yeah, go ahead.
I don't know if this is healthcare, but how would you approach questions asking about like the opioid crisis in America?
Yeah, so to be fully honest, I've never given a question on the opioid crisis, which is crazy, I know, but I have watched many speeches on it and also done a bunch of research myself. I think something that people don't realize is that, like, this is how fentanyl trafficking basically works. So, fentanyl precursors are imported from China to the United States. Precursors are the chemicals used to make fentanyl, in packages disguised as, containing other products. And because of the sheer volume of, you know, um, imports that enter the United States, it's nearly impossible for every single package to be screened, which is why these precursors, you know, which are already less likely to be detected than fentanyl itself, often just make their way into the United States unimpeded. Then they're smuggled to Mexico by US citizens, turned into fentanyl in Mexico, and then smuggled back across the border by US citizens. And the reason so many people make it through is because, number one, most cars aren't screened due to the sheer, amount of traffic entering the United States. And number two, because Republicans block the implementation of fentanyl scanners, like X-ray car scanners at the border for like 6 months. And even then are like refusing funding to expand the monitoring operations. Like there aren't that many articles out there, but aside from like the stock solutions of like increasing access to naloxone and things like that, that's also another big one. Scanning cars that enter the United States. Fentanyl is rarely produced in the United States. It's usually smuggled by US citizens into the United States from Mexico. So yeah, that's kind of how it works. I also think harm reduction is important. You can talk about increasing access to fentanyl test strips, which can help people test their drugs to, you know, find out if they contain fentanyl or not, because Another reason that people are dying from opioid overdoses is that they're buying things like meth, Xanax, etc., thinking that that's what they're getting. But in reality, they're taking pills laced with fentanyl, and if their tolerance isn't high enough, or if these pills have been cut with fentanyl too many times, um, the dose may be high enough to kill them immediately. And, by increasing access to fentanyl test strips and such, it'll help people avoid taking fentanyl. This does sound like a bit of a crazy solution, but if you phrase it well, and sell it, it can go a long way, yeah.
And then what about questions related to mental health?
Yeah. Well, I guess what's your question about this type of question?
Like youth mental health.
Oh, okay. I think social media regulation is always a good point to bring up. You can also talk about increasing coverage for mental health services, like mandating that mental health services be covered by private insurance and increasing coverage of mental health services by Medicaid. I'm gonna be fully honest, I haven't seen too many questions on mental health this year, but yeah, like I do think social media regulation is a point that you can bring up. And perhaps also increasing, to be fully honest, I'm not really sure what questions you're referring to still, but like I hope that makes more sense. And if anyone has a question still, I think I can take one or two more questions.
What would be your idea of like an on top, or I guess like another question is that would your impacts just always be about people, like whether it be good or
Uh,
bad?
I don't necessarily think so. That may not be strategic either. Like you definitely need to have at least one impact about people, but you can also talk about the economic effects of so many uninsured people. Like if people are sick, you know, it could decrease workforce productivity by a massive amount. Like it could literally plunge the United States into a recession. Like that may be a bit of a stretch, but like, you could talk about that risk. You could also be more specific with your um your person related impact. So it doesn't just have to be like X number of people will lose coverage or will die from preventable illnesses, but you could focus in on a particular demographic, like veterans or elderly people or a specific minority group that will be most affected. Because it's less persuasive and convincing to just throw around general numbers, but making your impacts more targeted can also make them more believable.